right. I think we'll go ahead and get started. I'm told it's pouring rain outside, so I think that probably has cut down people transferring. Well, are you still in Hampton House or have you moved out? You're still in Hampton House. Yeah. But it's great to see everybody here, and we've got a robust crowd and growing on the Zoom. So it's wonderful for everybody to come together, and we're in for a real treat today as we hear a fantastic presentation from Professor Michelle Spencer. So as you know, the Dean's Lectures are an opportunity for us to showcase the work of our newly appointed and promoted professors and senior scientists. We get a chance to hear how our colleagues are changing lives through their research practice and teaching. Today, we have the incredible privilege to learn firsthand from Michelle Spencer. Now, as most of you know, I think everybody is well aware that Michelle is the Deputy Director of the Bloomberg American Health Initiative and is a practice professor in the Department of Health Policy and Management. Michelle has deep experience working on community-based initiatives with a focus on addressing racial disparities and improving health equity and health outcomes. To put it in simpler terms, Michelle is just a public health powerhouse. She has made enormous impact in the city, in the state, in our country, working to dismantle racist and discriminatory health structures and build healthier communities. Now, what you might not know about Michelle is that she came to the Bloomberg School already with decades of experience in public health management and leadership. She served as the Chief of Staff for the Baltimore City Health Department for 8 years, and then served as Director of Prevention and Health Promotion for the state of Maryland. And in that role, she was putting the power of public health into action day and every day, overseeing core programs in maternal and child health, infectious disease prevention, and so much more. So we had the great fortune of welcoming Michelle to the School of Public Health back in 2016. And she came here to work with Josh Sharfstein to build the brand new Bloomberg American Health Initiative. Now, Josh will tell you that at that time, and I remember it well, the initiative was not much more than a press release. You know, it was a great idea, a press release. Yes, let's go for it. 8 years later, the initiative is leading the way in addressing the most pressing health challenges in the United States. The fellowship program, which Michelle created, brings 60 full-time scholarship students to the school from frontline organizations, public health organizations, and organizations outside the traditional boundaries of public health all across the country. Today, the number of Bloomberg Fellows, counting those that were just admitted, we're going to be welcoming 60 new scholars very soon. The total number is about 389, and they are working all around the country in close collaboration with some almost 300 different organizations around the country to address addiction, violence, food security, adolescent health, and environmental health challenges. Michelle also helped build the initiative's research and practice grant program, which funds hundreds of innovative projects across the United States. And she has overseen famous, if those of you who have not had the pleasure of going to one of our Bloomberg American Health Initiative summits, Michelle is the mastermind behind the summits. And if that's not enough, she leads the implementation of the initiative's high-impact projects, helping to advance work on key issues such as fentanyl testing and implementation of extreme risk protection orders. Her hard work and leadership on these projects and others has changed policy across the country. Now, of course, Michelle has also made a lasting impact in the Department of Health Policy and Management as well. She has been a true leader in the department's commitment to inclusion, diversity, anti-racism, and equity, partnering closely with Chair Keisha Pollock-Porter to elevate that important work. Michelle has also led advocacy efforts in Maryland for the Health Equity Resource Community Effort, testifying in Annapolis on behalf of the legislation in 2021, and currently serving on the Implementation Advisory Committee. This program will provide $42 million in grants to reduce health disparities and improve health outcomes throughout the state by addressing issues of housing, transportation, employment, food security, and more. Michelle is now working with federal legislators to design a national proposal based on this experience. We all admire Michelle, not just for her professional achievements, but also for her personal warmth. And I can attest to great hugs. It's a private joke between me and Michelle. And deep commitment to the success of everyone that surrounds her. Her door is always open, and she is known for being kind, compassionate, and a partner to everyone in the department and the community at large. Now, for anyone who attended the most recent summit, you may remember that it ended with Josh and Michelle on stage, and Josh insisting that they take a selfie. And Michelle is saying, "What are you talking about? We can't take a selfie here. There are too many people." And Josh said, and many of you in this room are wondering if indeed this selfie ever made the light of day. And here you go. This is the selfie they took. This was the last summit. I remember it well. And I just absolutely love this photo because it gives such a hopeful picture. It's a reminder of the strength and the reach of the initiative. It shows that we have built an incredible network of public health champions driving us forward with amazing leaders, Josh and Michelle at the helm. So Professor Spencer, the initiative would not be anywhere near what it is today without you and all your incredible talent and commitment to the initiative and to public health. And we're so excited to hear from you today. So Michelle, the floor is yours.
Thank you, Tim. I appreciate that. And thank you, Ellen. I feel like, oh, wow, Ellen, you did all of that. I should just say, great, I'll see you all later. This is good. So let me again thank you, Dean McKenzie, and good afternoon to all of you who are here in the room and all of you who are in the virtual space. I am thrilled and I am humbled because I know that you could be spending your 4 p.m. Tuesday afternoon anywhere, but you are choosing to spend it with me. And I recognize the importance of this moment and the magnitude of this moment. And I am grateful and I am humbled. And so I'm going to jump right on in and hope that I have saved time at the end for questions and to engage with you all. So let me begin by sharing that 2 fish were swimming in tropical waters. One fish said to the other, "Hey, how's the water?" The other fish said, "What's water?" Interesting. So the World Health Organization's Commission report in 2008 on the social determinants of health, Closing the Gap in a Generation, noted that social justice is a matter of life and death. It notes that avoidable health inequities arise because of the circumstances in which people grow, live, work, and age, and the systems put in place to deal with illness. It goes on to say that the conditions in which people live and die are in turn shaped by political, social, and economic forces. This afternoon, I'll share a bit about Maryland's Health Enterprise Zone Initiative, a policy lever to reduce disparities and address health equity. I'll talk a little bit about the cost and burden of health disparities, the response, the zones, the outcomes, lessons learned, impact, progress, and on the horizon. But first, I want to level set for those of us in the room and those of us online. And forgive me if this seems a little bit elementary, but it's important that we're all on the same page. So disparities are the differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups. Inequities, specifically health inequities, are the differences in which health are the differences in health, which are unnecessary and avoidable, and considered unfair and unjust. So, the cost and burden of health disparities. So, Maryland has a total population of 5.8 million. We all live here, we all work here, we all play here, but let's make sure that we know what's happening in our state. The state is divided by 24 jurisdictions, including the city of Baltimore. It's the 9th most diverse state in the country, with racial and ethnic minority disparities accounting for about 45% of the state's population. 4 jurisdictions have greater than 50% minority populations, 6 jurisdictions have greater than 40%, and 9 has greater than 33%. Prior to the implementation of ACA and the expansion of Medicaid, Maryland had approximately 720,000 individuals that were uninsured. Though very preventable, chronic diseases are among the most common and costly health problems in the country. In Maryland, chronic disease disproportionately impact those of lower socioeconomic status, those with less than a high school education, and those within communities of color. Throughout Maryland, in every county where rates have been reported, we know that there are enormous disparities. So thinking about how we address the burden, we're thinking about the social determinants of health, which we know are the non-medical factors that influence health outcomes. We're thinking about healthcare access and financing. We know that approximately 3 million individuals nationally who have eligible people have opted out of Medicare expansion in terms of those states. And we know the opting out of Medicaid expansion prolongs health disparities. And we think about the policy levers, identifying opportunities and policies that can strengthen programs, and thinking about what are some of the policy levers that we should be considering as we're thinking about closing the gap in these inequities. The Institute of Medicine back in 1999 noted that the determinants of health are beyond the capacity of any one practitioner or discipline to manage. It notes that we must collaborate to survive as disciplines and as professionals, attempting to help our communities and each other. So, I see Dr. Gaskins in the room. In 2023, a special communication of JAMA by Dr. Tom Leviste and Dr. Gaskins noted that the economic burden of health inequities is unacceptably high and warrants investments in policies and interventions to promote health equity for racial and ethnic minorities, particularly those with less than a 4-year college degree. We see here that minority health disparities cost Maryland between $1 and $2 billion per year of direct medical cost. The findings of that JAMA report went on to say that the economic burden of health inequities for racial and ethnic minority populations was $421 billion or $451 billion, and the economic burden of health inequities for adults without a 4-year college degree was between $940 billion and $978 billion, according to 2 data sources. High cost individuals. The National Association of Accountable Care Organizations noted that high-need, high-cost persons are those living with clinically complex needs and functional limitations who also incur high healthcare costs or are likely to do so in the future. Despite engaging frequently with healthcare systems and substantial medical spending, the physical, social, and behavioral health needs of these persons often remain unmet due to fragmented and uncoordinated care. You will see here that admissions and readmissions account for 84% of the high-need, high-cost individuals to the healthcare system. And you'll also see that those who are frequent and repeated ED utilizers account for 82% of those individuals. So, in Baltimore, we recognize that even 5 miles makes a world of a difference. If you live in Roland Park versus Madison East End, you see that life expectancy, there's an 18-year gap. and over a $60,000 annual income gap. We also see variables in unemployment as well as violence between these two neighborhoods in Baltimore City. We found at the time at the state that the areas with the worst health outcomes and the largest health disparities were also the most expensive for the state to address. What was the state's response? So, in 2012, the first of its kind, Senate Bill 234, sought to reduce health disparities among Maryland's racial and ethnic groups and across geographic areas. It sought to improve healthcare access and health outcomes in underserved communities and reduce healthcare costs by establishing the health enterprise zones. This was a pilot program. It provided $4 million a year for 4 years. You'll ask, what's a HEZ? An HEZ or HEZs are designated local communities with documented poverty, health disparities, and/or poor health outcomes, where special incentives and funding streams are available to address health outcomes by using healthcare level, community level, and individual level interventions. So, HEZs must be a community or contiguous cluster of communities that are defined by zip code boundaries. It must have a population of at least 5,000. It must demonstrate greater economic disadvantages and poorer health outcomes. It must be a population that was small enough to allow the incentives offered under the Act to have a significant impact on improving health outcomes. You're like, Michelle, what is this? It looks really busy, but I will say to you what the state was able to do was to provide a database where zones or communities were able to indicate their zip code. They produced these maps, and communities were able to see the average life expectancy by zip code, the average percent low birth weight, Medicaid enrollment rates, and WIC enrollment rates. Communities were able to use the data to define their target communities when submitting applications. So there was a call for proposals. 19 applications from 16 jurisdictions were submitted. Remember, I told you Maryland has 24 jurisdictions, so over half of the state were interested in understanding and applying for these funds. 19 applications were received across 16 jurisdictions. 5 zones were designated, representing rural, urban, and suburban areas. 3 were led by coalitions of hospitals, health systems, and 2 were led by local health departments. Each zone was unique and tailored its program and resources to meet the needs of their specific community. The Office of Minority Health and Health Disparities, we used the logic model, and its 6 key strategies became the HEZ's principles. These principles were incorporated in the application review and the criteria. We noted that the zones were addressing a number of social determinants needs, including those of transportation and education, healthcare access, language, and cultural barriers. Incentives under the HEZ program. Some of these incentives and resources provided by the HEZ were to help attract new practitioners, to expand services in underserved areas, and to address these persistent disparities. These included income tax credits, grants, loan repayment assistance, and employer hiring tax credits as well. I should note that at the time of HEZ implementation, a number of things were happening across the country, and so I just want to note that. ACA was ending its first open enrollment period, the Affordable Care Act, to be clear. Maryland is a Medicaid expansion state, meaning that we made Medicaid available to low-income, non-elderly adults, which was one of ACA's main tenets to reduce uninsured rates. We were part of the global budgets, the all-payer model, which focused on value of care and not volume of patients. As a matter of fact, Hospitals were not paid if patients were readmitted less than 30 days after discharge for the same condition. And we were also integrating community health workers in the patient-centered community-based model, understanding the significance and the impact of community health worker in the interventions on disease management and health outcomes. Okay, so a little bit about the zones. Are you all tracking with me?
Yes.
I love it. Thank you. Are you all tracking? Okay, I need that energy. So thank you. Okay, so the zones, here we go. And sorry online, I can't see, but I suspect that you are telling me thumbs up to keep going, so I will do that on your behalf. So the zones. I am not going to read all of what is on the slide here, but I will tell you Morris Blum is in a suburban area. It's in Annapolis. The population that was targeted was 37,000. And this particular zone was ran by Anne Arundel Medical Center. The Annapolis Medical Center established a healthcare center in a senior housing residence to address chronic calls to the 911 emergency center for chronic conditions that certainly could be treated in the home and in community. I will tell you that one of those 911 frequent callers is Mr. P. Mr. P was very much interested in always being in community with folks. He would call 911. He felt like he needed to go to the emergency room. He would be shipped off to or carried off to the emergency room. He would get there and they would realize that Mr. P wanted compression socks and he wanted to be amongst other folks. His chronic conditions, the things that could be handled at home, was not something that he needed to be using the 911 emergency system for, but that is what he did. What ended up happening when this particular clinic was open in a housing authority, Mr. P was given the job of greeter. We know that our Surgeon General Vivek Murphy in 2023 noted the impact of what he calls the epidemic of loneliness and isolation in the US. And that is one of the driving factors we saw with Mr. P, needing to be in community with others and utilizing the 911 emergency system as a way to be in contact with others. Greater Lexington Park, rural community, 36,000 was the targeted population here. One of the things that Dorchester Caroline focused on was care coordination with their local health departments, their school-based programs, and their community-based organizations. How were they able to think about expanding access to peer recovery support specialists, thinking about weight management and school-based asthma management programs? Again, what are the things that can be done in community and without utilizing the 911 system? Greater Lexington Park, the population focused on 34,000. It's in rural St. Mary's County, and this particular zone was administered by MedStar St. Mary's Hospital. I will tell you that health literacy was one of the most important drivers there. I will tell you that transportation was a concern and an issue, so much so that police cruisers that were going off of service were being converted so that individuals in community could use those cars and use that as part of the transportation route, recognizing the transit system was not necessarily transit friendly to those in rural St. Mary's County. St. Mary's County was clear about coordination at home and what that care coordination looked like. In terms of health literacy, I can tell you about the patient that she didn't have a good understanding of how to read her husband's medication. Her husband was often seen more necessarily in the emergency room for dialysis because of the way his treatment was not being administered at home. And so these are what we were able to do when we realized that was to coordinate with a community health worker who would be in the home with that family to ensure that they understood how to take meds, to understand help with that literacy. One of the other issues was that she could not see. So she needed new prescription glasses, and those were one of the things. And these may seem as small measures, but remember that we are addressing those social determinants issues to keep individuals out of the emergency room and address care at home. These are some of the things that we were able to do through the Health Enterprise Zone Initiative, specifically at this point in St. Mary's County. Prince George's County. Prince George's County focused on 39,000 individuals across zip code 20743. It's a suburban area. They were able to establish 4 patient center medical homes, one specialty care practice. They created the community care coordination team, which they met on a monthly basis with fire, EMS, housing, social service, and a number of wraparound services, ensuring that they implemented health information networks and develop a comprehensive health literacy campaign. They established the Primetime Sister Circle to ensure, which is an empowering circle for women to take control of their health, to really reduce chronic illness, to support healthy eating, and to reduce obesity and promote health literacy. Again, very specific and targeted to what was happening in their community. And finally, the West Baltimore Primary Care Access Collaborative was done in West Baltimore and was overseen by Bon Secours Baltimore Health Systems. They focused on developing a tiered care coordination program, really targeting high utilizers of the emergency room, recognizing who those individuals were and really thinking about how they coordinate their care in community. They had lots of small grant programs to community partners to help really think through what were some of those opportunities in terms of addressing food deserts, fitness classes, having a number of classes that were available after hours, including childcare for individuals there in community as well. And so, what are some of the outcomes? So, I'm always told by communications not to bury the lead. And so, the findings from the evaluation were published in October of 2018 Health Affairs. This evaluation was done by Dr. Gaskins, Dr. Roland Thorpe, and others. And the findings indicated that the net cost savings from reduced inpatient stays far outweighed the initiative's costs to the state. It noted that implementing such initiatives is a viable way to reduce inpatient admissions and reduce healthcare costs. This is where I think the magic of government and academia meets the needs of community. So a little bit, again, the evaluators were those here in the Centers for Health Disparities Solutions. They divided Maryland zip code into two categories: HEZ awarded zip codes and HEZ eligible but not awarded zip codes. The evaluators compared zip codes before and after HEZ periods of 2009 to 2012, and then again between 2013 and 2016. We see the decline in the total discharges from 2010 to 2016 was about 32% in the HEZ zip codes compared to 24% in HEZ eligible but not funded zip codes. And this was specific for inpatient stays. In terms of HEZ-related conditions, those are hypertension, chronic disease, obstruction, pulmonary disease, and such, and PQIs, which are preventable quality indicators. And these are preventable conditions that, with evidence, we see these conditions can be treated in community and have good outcomes and don't necessarily need hospitalization if they're good interventions that happen within communities. We see the downward trend for awarded and non-awarded HEZs for PQIs. HEZ awarded zip codes are falling faster, we see here, than the HEZ eligible but not awarded zip codes. In terms of emergency visits for HEZ-related and PQIs, we see that they fell faster in the HEZ awarded than they did in the HEZ-eligible zip codes between 2015 and 2016. During 2015 and 2016, I would note that that's when care coordination programs really matured across the HEZs. And you'll see that noted here. So, findings from the evaluation also noted in terms of cost savings. It noted a cost savings of $93.4 million for Maryland's healthcare system. The evaluation noted that the state spent $15.1 million on the initiative in the same period, and combining that amount with a net reduction in charges of $108.5 million suggests an overall net savings of $93.4 million for Maryland's healthcare system. Are you all tracking? Awesome. So, what were we able to do? We expanded capacity to deliver services through the expansion of 21 healthcare delivery sites that were open or expanded. We hired or added almost 100 full-time employees, including licensed independent practitioners, certified healthcare practitioners, and community health workers. We awarded over $327,000 in income tax credits to 34 HEZ practitioners and 19 HEZ practitioners. We were able to award loan repayments assistance. We had over 346,000 visits to almost 200,000 patients, care coordination of targeted high utilizers, and we certainly use data to link these individuals to care management and care coordination in community. So what are some of the lessons learned? Timing, time and timing, the opportunity to provide a planning year to refine strategic plans and develop relationships. 4 years is not long enough to build trust in communities, to acquire and rehab building space, or to leverage new initiative in the healthcare system. Data collection, establishing data use agreements, we needed more time for that. Innovation, accounting for the broader healthcare environment, more flexible recruitment and retention for the incentives, and funding for equipment purchases and leasing. I told you we expanded or built new healthcare sites across these 5 zones. Also, provider recruitment and retention was critically important. Working with complex patients in terms of providers having an understanding of what that meant and what it means. Patient and community engagement, policy and advocacy efforts, and thinking about the clinical and community care, the balance between community and provider-focused intervention, and certainly more than additional providers was what was needed in these specific zones. So the impact and the progress. So the program was associated with improved healthcare access and reduced inpatient admissions. Policymakers, per this paper, it was noted that policymakers should consider promulgating the interventions to other eligible communities. It noted that additional support could be provided by the health plans that benefits the cost savings as a result of lower hospital utilization, or hospitals could fund additional zones as part of their community benefit responsibility. This is an example of policy implementation and translation working to improve population health by tackling inequities through community innovations. Recall what I shared earlier regarding social justice. I said that the conditions in which people live and die are in turn shaped by political, social, and economic forces. To be clear, 4 years to address structural systems of racist policies that perpetuate disparities and inequities was not a lot of time. 4 years and $16 million was not a lot. It was an effort. We were able to do a lot with that, and we are grateful with what we were able to do. But it's important to note that that was a heavy lift. It included incredible collaborations to address population health across our state. We had favorable outcomes. We improved outcomes and access to primary care. We developed community-level programs. We informed innovative approaches. We reduced disparities and addressed inequities. We demonstrated effective academic, community, clinical, governmental partnerships. We did a few other things as well. We got some awards. We got some consultations across many states in the country. Folks were looking to replicate this in Rhode Island and Philadelphia and New York, and we had lots of discussions around that. Robert Wood Johnson Policy for Action proposals were submitted. We have publications and manuscripts, and we even did a podcast on public health on call. In 2021, House Bill 463 was introduced. So I told you, that was in 2012. I'm taking you now to 2021. House Bill 463 was introduced and supported by advocacy, community-based organizations, and previously awarded health enterprise zones. Congressman Anthony Brown introduced House Resolution 4510 in the 117th Congress, and we advised his staffers on what a potential legislative item would mean for the country. The legislative session was a win for Marylanders on many fronts. House Bill 463 was passed, creating the Health Equity Resources Act. Unlike the 2012 law, the HERC law is permanent and has a dedicated funding mechanism for at least the next 10 years, with similar goals: to reduce disparities, to improve outcomes, to improve access to primary care services, to provide primary and secondary prevention services, and to reduce healthcare costs. As Ellen noted, I have the privilege to sit on the advisory council for the HERCs, advising and supporting on this new legislation. And at any moment now, we will learn of the additional zones, the $45 million so I should say that $14 million were awarded in May of 2022. That funding, those grants, ended just a few weeks ago on April 30th. And we have $45 million additional dollars for the health equity resource communities. These grants, which are to begin any moment now, and they will end April 30th of 2029. We were able to these are being administered by the Community Health Resources Commission, and every day I check to see when that announcement will be made. We provide technical assistance and healthcare provider loan repayment assistance as part of this legislation as well. And this legislation, of course, was mirrored after Senate Bill 234 back in 2012. So I don't have my collaborators from the Office of Minority Health and Health Disparities in this space, but we do have the chair of the HSCRC in this space who can speak more broadly to this. But I will share with you that last month in an independent 131-page report by Mathematica, it released Maryland's total cost of care model for the first 4 years. The independent report submitted to the Centers for Medicare and Medicaid Services was favorable to Maryland and the total cost of care model. It noted that the model positively affected spending. The model generated $689 million in net savings to Medicare. It showed evidence of decrease in hospital readmissions, and the model reduced disparities in unplanned readmissions, prevention admissions, and timely follow-up by race and place of residence. What is so incredibly important is I shared with you how the Office of Minority Health and Health Disparities was part of what we looked in terms of engaging with them at the onset of ensuring equity, ensuring health literacy in the review of the HEZ applications. Well, for the Office of Minority Health and Health Disparities, they will be leading the Population Health Transformation Advisory Committee that is tasked with ensuring equity-centered population health improvement approaches in this new AHEAD model. And so very excited to see full circle of where we were in 2012 and this submission of this application by the state. So you're like, Michelle, you shared a lot. You took us from 2012. You brought us to this submission of a 2024 application to the AHEAD model that we're not even sure what that is quite about. But here's my why, right? I shared a lot, and that's okay, but I'm going somewhere. And I kept asking you if you were tracking, and you told me that you were, right? You told me that you were. And online, although I can't see you, I know the thumbs are up that you're tracking with me as well. So, my why. I am first generation college graduate. I recognize the sacrifices of my parents moving from Barbados. When I was 8 years old, when I was going off to college, we went to a very small church, and I was the first to leave that church to go away to college. And my pastor prayed for me. As he was praying for me, he said, "You are somebody's dream." And those 4 words are what I take with me. Now, being in Maryland, away from family, in the different spaces that I worked in, I am affiliated with First Mount Olive Baptist Church. And I was having a moment, and I went to see my pastor. And he said to me, "The threads of your life are perfectly woven together." So let me tell you this. Growing up in Brooklyn, Halloween was not what you would experience and what I experience here. In Brooklyn, East New York, Brooklyn, Halloween for us was the night of gang initiation. So on Halloween, you went from home to school and from school directly home. And you stayed inside and you made sure you got home before it got dark because you did not know what that would mean for you. I'm telling you a story. So just keep, right? You're tracking. All right, keep tracking with me. The thread of your life are perfectly woven together. So I went to Murray Bertram High School in New York City. I have 14 minutes. Okay. Kidding. It's not at all. So I went to Murray Bertram High School. While there, I worked at the New York City Health and Hospital Corporation. When I left New York, I went, I got my undergrad degree. And while I was working on my master's, I worked at Memorial Sloan Kettering Cancer Center. When I left MSKCC, or when I left New York, I worked for the cancer program at the State Department of Health. When I left the State Department of Health, I went to Baltimore City Health Department as the Chief of Staff. As the Chief of Staff at Baltimore City, I was responsible for some special projects and some special programs. There, I led the Safe Streets program. When I left Baltimore City Health Department and went to the state, I oversaw the Prevention and Health Promotion Administration that focuses and houses all core public health programs for the state of Maryland. There, I was also tasked with some special projects, one being the Health Enterprise Zone Initiative, and another, I was designated for a period of time to the Maryland Health Benefit Exchange. And now here I am. You're like, "Michelle, how does that all fit?" I will tell you that I think I'm the vehicle bridging the work of academia and the community between research and practice, doing what I love and making an impact in the way that I have been called to do. My trajectory here has not been linear. It has not been the academic way, but it is my story and it is my way. And it is how the pieces and the threads of my life are perfectly woven together to bring me to this specific moment. And I will just say that I recognize that I am the dream and the reality of the dreams of so many individuals, those that pray with me, continue to pray with me, those that have gone before me, and those who I may never meet, but I recognize that. And so let me just share with you that systems change. You're like, Michelle, you went from that back to this, but it's important. Systems change is about shifting the conditions that are holding the problem in place. These conditions exist with varying degrees of visibility to the players in the system, largely due to how explicit or tangible they are to most people. This model of transformative change was described in a paper by Kania, Kramer, and Singh. The changes we wish to see in our innovative approaches require a continual focus on the less explicit conditions, with a shared vision that propels us to see beyond our own disciplines and beyond the traditional conventional paths. May we always know and understand the space and greater impact of our work. May we always be willing to drill deeper and work harder towards transformative policy changes that support health equity. May we never be like the fish asking, "What's water?" So, there's so many individuals I would want to thank. Certainly, I thank God for this moment, for bringing me to this space, for bringing me to this moment where I said to Ellen earlier that it was an invitation and I should have just declined it. I was like, I don't know if that was an option, but I could have declined it. So I thank God. I thank God for this. And I thank so many people that are listed here for always being so supportive and so very, very, very inspiring. And I want to thank my family. My family is huge. And so I'm just so grateful for them, for their support, for the constant that they are in my life, and for the push that allows me to be in this space. And I always say family first, and nothing can be done without them. And there's some folks, the initiative team, they're just so wonderful. They keep me grounded. They support me, even when I don't know that I need the level of support that they give. And then there's some people that just hold you up. I'm so grateful for my chair, for my faculty advisor, Dr. Keisha Pollock Porter, for her push that is never ending, that I know comes from the best place ever. I'm so grateful for Josh. There's so many words, and yet not enough. And to Akola, who keeps me grounded and who's forever so inspiring in the way she just shows up, in the way she helps me do what I do. And then this is my mom and my brother, and I'm so grateful to them. They mean the world to me, and I say to them that this moment and this time is for you and for our very, very little island of 185,000 people, our little island, Barbados. And I would say big up, yay! And so with that, I yield my time and thank you.
I don't know what to say, Michelle. That was outstanding. We are so fortunate to have Michelle. I think you'll all agree with us. We're so fortunate to have you here at the School of Public Health and as one of our inaugural practice professors. It's just so incredible. You bring so much to the school, to the field of public health, to the communities. It's just, we're just so grateful to have you and to work alongside you and to share with you and and learn from you. I learn from you a lot, I will say. Thank you. Questions? I don't know if they're questions or just wow. I should give people an opportunity to ask questions if they'd like to ask questions.
It was a great presentation, Michelle. I wanted to give you a tissue. Thank you, Mary.
Or we could just adjourn to the Wall of Wonder and celebrate Professor Spencer. Oh, no, we have a question. Okay. Sure.
Still stuck in wild gratitude. So I asked a question. Really, so I used to do like community engagement work as a facilitator. And we saw from county to county, the curriculum was adapted to each county, like each class and what have you. In terms of lessons learned and being inspired, like from your community workers, how'd you see them like adapt to the circumstances in each of of the different zones?
Yeah.
Does that make sense? Sorry.
Yeah, no, it does. So each community had one, every zone was unique, and every zone was unique. And so community healthcare workers were not employers of the state. Those community health workers came from those specific communities. I will share with you that when I began overseeing the zones, one of the things that we recognized had not happened was the state had not been to each of these communities. The state had never done a site visit. And so we sat at the state expecting data and expecting very specific outcomes and very specific deliverables without going into these communities and having an understanding of some of the challenges. And so in terms of community health workers, one of the things that we recognize is that we looked at the model, particularly what was happening in Prince George's County around their care coordination, where they looked at getting all the social service departments and agencies together and having to see what those wraparound services would mean if we did that similar model in each of the various zones. And we saw an impact, and we saw some of those declines begin to happen when there was that level of coordination with individuals who were trusted in the community, not necessarily with those of us coming from the state saying, this is what we need, but how can we support individuals in community, giving them funds to do the work, helping make those connections with those individuals, and then creating space for them to actually do the work that was meaningful and impactful. Of course.
Any other questions? Yeah. Oh, that doesn't work.
Thank you so much. That was wonderful. I'm gonna read my question so I don't botch it. So grant-based funding cycles for public health, I feel like have pros and cons because, we can enable communities that are facing disparities to opt in when they need more support, but it can be inconsistent as well. So what do you think the lessons from the HEZ project can teach us about how to implement more permanent public health funding that is targeted for disparities?
Yeah, thank you for that. The first thing that comes to mind is to be able to show outcomes. When you're able to show outcomes, you're able to show why there's value in the work that you're trying to do. I think what we're able to accomplish in 2021 with that new legislation, with $45 million in grants about to go out the door, is based on what we were able to do in that 4-year period with $16 million. I think it's also helpful to have great evaluators thinking about the Centers for Health Disparities, what they were able to do in terms of helping us narrowly define what are some of the measures that we should be thinking about, what are some of those outcomes we should be measuring, so that at the end of that 4-year period, we can be able to say, because of this, we were able to see reductions in ED utilization. We were able to see reductions in 911 calls. And so that you have a story to tell with data, right? I forget that line, right? Like, in God we trust, everyone else bring data. And so it's like super important that you have that to show the story, to be able to say, we want, and I think, the HEZs is such a great example when we have other states saying to us, how are you able to do that? And I just want to be clear, and I should mention that Dean Reese at the time at the University of Maryland, Shirley Nathan Pulliam, Daryl Gaskins, Dr. Carlicia Hussein were the individuals, and Josh Sharfstein were the individuals behind this piece of legislation. And having individuals and champions at the federal level within government who are able to champion this and who are able to say, what are the supports that you need to do this work, is critically important as well. And so when you go for those then grant applications, you are able to have supports of those who are elected officials, of those who are within federal and state agencies to help you get that application out the door and help you to be successful. Dr. Yes.
So we do have a question from Khadija online, and then we'll go to Daryl. Khadija, can you hear me?
Yes, I can, but I'm actually kind of sick, so my voice is a little scratchy. Can you hear me okay?
Yeah.
Okay. Michelle, thank you so much for your talk. It was amazing. Brooklyn, stand up. I'm also a West Indian girl from Brooklyn. But I wanted to ask, as someone who has lived, I used to live in PG County, and I have family there, and so I knew there was a kind of significant Caribbean kind of subpopulation there, if you will. Did you notice any difference in terms of with the HEZs? Were there any differences in engaging with people of Caribbean background during the HECs, or was it like, I don't know, I guess too small of a community to know any differences in terms of engaging with that population?
Yeah, so thank you for that, Khadija. So for that specific, remember that the zones are based on zip codes. And so when there were community meetings or opportunities to meet with community, it wasn't, I can't say specifically that it was more Caribbean, those of Caribbean descent versus those of African American descent or others. But I will share with you that health literacy was one of the main driving components in Prince George's County, and we recognized that. And Dr. Carter, who led that zone, was very clear in the need to have culturally competent literature to ensure that what we were saying and how we were engaging the community in Prince George's County was based on what was culturally relevant and appropriate for them. So while I can't say specifically that there was a difference, we were certainly aware of how we needed to approach that community based on what was culturally appropriate.
Well, first of all, Michelle, congratulations. This is a well-deserved honor. Wonderful talk. There's some of us that get to observe the sunrise and say, "Wow, it's warm. It was warm," and that's sort of what we evaluators do. And then there's other people who cause the sun to rise. And that's sort of the stuff that you do. I tell people that I don't do anything. I help watch other people do things, and I tell people how great they're doing it and that they should help them continue to do it. And so as someone who sort of made this thing work, that actually got in the trenches and made it work, could you, if you share with us um, one or two observations about the joy, because you bring so much joy to the work that you do, and also the frustration and that of trying to do this kind of work, because it's not easy. And we don't save that much money unless somebody like you and the people who you're working with actually cause the sun to actually rise.
Well, thank you, Daryl, for that. I didn't think of myself as helping the sun to sunrise. Thank you. Wow. The joys are in getting to meet individuals who are in the trenches, the public health practitioners, the folks who are actually doing the work day in and day out, whose names will never be mentioned, who will never have an opportunity to stand before you. They are the public health heroes. They are the ones who are out there doing the work in that way. They're the ones who we are trying to champion. They're the visionaries and they're the implementers. And it's a joy to be able to be in spaces with them and to be able to learn from them and to be able to work alongside them. I think one of the challenges is ensuring that you're able to share the importance of that side of the work. That while it is so incredibly important that we are doing the research and that we are publishing our work, I think it's so important and critically important that we are able to show the importance of research and that we're able to translate that to the communities that need and require that help from us in academia. And I think we've been able to do that, and we will continue to do that. And that's both a challenge and a blessing. And it's inspiring to be able to work with and learn from researchers in this space, each of you, and from our students. And I don't like the word staff, but team members in the various spaces that we occupy here at Hopkins and across different academic institutions that show us and humble us in the way that we approach this work. You know, can I just give a shout out? And I know we're over time by 4 minutes, but I'm just so appreciative to, I had a slide that thanked so many individuals, but there's some folks who are just so incredibly gracious um, and I don't want to miss anyone, but I certainly appreciate the initiative team and for always showing up. There's something to be said when you have Cass and Daniel show up early and say, I'm going to sit in the middle and I'm going to cheer you on. And I'm just so appreciative. Daniel was very clear when he said to me, I want you to co-teach this class with me. And it meant the world to me. And it continues to mean the world to me. And every time we have a class, he's very clear to say Professor Spencer. And it still gives me moments, but I am so appreciative. And I think being on this side, to be able to see how the sauce is made with so many of my colleagues in FDC is so humbling. And I so appreciate all of the lessons and all of the supports from all of you that keep supporting me and keep lifting me. So thank you. Thank you.
I think that's a good note to end on. And please join us at the Wall of Wonder and to celebrate Michelle and all that she continues to do. Now I